Today we will learn how can we form the anterior chamber at the termination of phaco surgery. So we all know that phacoemulsification requires a self-sealing small incision so that there is no suture required for its closure. And how this closure is achieved in a self-sealing incision, this is what we are going to see and discuss. So there are situations when at the end of the phacoemulsification there may be inadequate anterior chamber sealing. So first we'll see what is the most normal and ideal condition where you have an incision where you simply inject the fluid into the anterior chamber, which increases the intraocular pressure and it seals the self-sealing valvular incision. So in this video we can see fluid is being injected and we can see that the cannula is kept outside so that the fluid enters but it is not opening and leaking out. This is the post-op picture day 1, which shows anterior chamber which is formed and rest of the things are as expected. There can be a situation when this simple inflating of the anterior chamber may not cause proper sealing, and this may be because of various factors, which may be because of failure of this valve. So once we inject fluid, we find that the anterior chamber is not turgid and the eyeball pressure is low. So first thing to be done is you can hydrate one of the incision valves, and at times this will help. Here we can see that. And then this is the post-op day 1 picture in this patient. We can see the chamber is well formed and the surgical outcome is as expected. Coming to a situation where simple hydration of one side of the incision may not help. So here we'll see that the inflating the anterior chamber didn't work. The surgeon is hydrating the one side of the wound and again testing, and it is still hypotony. The eyeball is not turgid. So what you can do is you hydrate the other side. So tapping the cornea will ensure and a rebound which should occur in a sealed incision is missing, then it means that the chamber is leaking. Once both the ends or both the sides of the incision are hydrated, the valvular incision becomes thick and strong enough to provide sealing of the anterior chamber, and the chamber is formed and sealed. This is the day 1 post-op picture of the same patient, and we can see the chamber is well formed and the surgical outcome is good. Ultimately, there can be a situation where these maneuvers simply don't work. Then one can resort to placing an air bubble in the anterior chamber. Now we all know that air has a higher surface tension when it comes to an interface which is formed by the air and fluid. So the thin film of fluid which is lying at the junction of air and fluid interface, it has a higher sealing capacity, and though this incision may not seal with simple hydration, it may seal with placing the air bubble in the anterior chamber, and this is what is being demonstrated. And this can happen usually in individuals who are younger age group, in whom the cornea and sclera is more elastic, and as a result the wound is unstable. So placing an air bubble in the chamber can do the job without a suture. However, this is the problem. Placing an air means that the optical quality of the eye itself is altered, and so patient has very poor vision. And if the surgery is done under topical anesthesia, obstruction to the light and image formation is compromised, so the patient's vision is not optimum. And this is day 1 post-op picture where you can see half of the anterior chamber is filled with the air bubble, and as a result the patient will not have very good visual outcome on day 1. So ultimately the patient will regain vision, But this minor inconvenience may be there, but the point is that you may avoid placing a suture which can actually add to the pre-existing astigmatism or accentuate the astigmatism, so you can avoid that long-term astigmatic effect of the suture by placing an air bubble in an anterior chamber which is not being sealed by fluid and hydration of the wound. Thank you.